That is something which is more of a theory, most of a theory. I think I have met good cardiologists who are very they are convinced that CTC is the way forward, especially the patient who are low to intermediate probability of having coronary artery disease. And once we give them the disease, we tell them that this is the disease, this is the segment of the disease, rather than hunting in dark. They know it when they go before the cath. This is like the disease and this is the size of stent, this is the length of the stent. It is just like, driving a Mercedes-Benz vis-a-vis and Bulla cart, doing a catheter angiogram on the first instance.
So Dr. Sedation, you did the first few pediatric CTCA, so what difficulties have you faced there at AIIMS Patna?
So first, we were doing for congenital heart diseases, but we tried to reduce the number of phases to reduce the radiation exposure, and we were not able, and we did not use ECG gating to reduce the radiation exposure. But with the protocols that Sir had us made, the scans are ECG gated, 2 phases, and then the radiation is within limits. So with pediatrics, the first is the scan duration should be very less. Then was the other problem was heart rate, which Sir had come to Patna regarding some conference related to Kawasaki disease. It was at that time when Sir told us to contact him, and we asked our engineer to talk to Sir, and then we made protocols, 70 kV, 80 kV and 100 kV protocols. So in children, like earlier we were using 100 kV for all patients, all CT scans. So now we have the 70 kV protocol and the 80 kV protocol. So right now we did a case for a 5-month-old child with congenital heart disease. We did a scan with the 80 kV protocol, and we got very good images, and the radiation exposure was also very less. Right now also, 2 days before, just before coming here, I did a case with Epstein's anomaly. We got very good images because they were ECG gated, and the radiation exposure was also...
what was the radiation exposure?
So 1.2 millisievert. 22 years.
And how did you sedate the baby? And who sedated the baby?
So that pediatrics people had done. So for the 5-month-old child.
Yeah, that is the way it has to be done.
Yes.
The pediatrics team has to be there.
So Pratap Patra sir was here actually,
Yes,
so
yes.
he helps in these cases.
So here, I mean, the scans are done in the presence of the radiologist, not the radiographer. The radiographer is there, but the radiologist himself has to be physically present there to tinker with the controls. And that is how you decrease the radiation to much less than 1 millisievert. With the latest machine that we have, the 384 slides, 386. So much less than 1 millisievert, which is about the lowest in the world, about the lowest radiation exposure in the world. And the information that you get is, that has changed the way we understood Kawasaki disease.
I tell you, I get an opportunity by God grace or by whatever University of Bristol, University of California, and good centers across the world. You won't believe, how this living modality has come way, and it has generated so much of enthusiasm among the pediatricians, pediatric cardiologists, pediatric rheumatologists. How this imaging, which probably seems underutilized, can be the modality of choice or the standard of care in the days to come. So this, I would like to have closing remarks from Tapasar and please.
So can I mention something?
Yes, please.
So in the eastern part, I come from the eastern part of India, where in both the centers like Arantigar and Narayana, we have developed a protocol, and for the last about 10 years, from 2015 to 2025, our cath proportions have been approximately 65 to 70% has been the interventions, and with 30% has been diagnostic. The diagnostics has mainly been limited to, as Sir said, the prefontaine caths and the diagnostic ones where we had collaterals which had to be coiled, like large major pulmonary collaterals, or we did some oximetry hemodynamic studies where the hemodynamics was important because we had some late presenters, for example, large left-right shunt lesions presenting at the age of 2 or 3 years, or maybe large univentricular ones before going for whether that can still be reversible or not, such cases. So those are extremely less now. We have a CT scan protocol The sedation is given mainly by our pediatric residents who travel along with the patient, along with all the emergency medications, bag mask, resuscitation, everything. The radiologist and everyone is keep in standby. The radiologist mainly does the protocols. Most of our CT scans are protocol based, and we reconstruct the images, and we are happy to say that most of the reading is also done by us only, because we can see by our PAC system, we can read the CT scan before the radiology report comes, the point of interest like the branch pulmonary arteries or the relationship with the great arteries, or even the shape and size of the ventricles on all the cardiac structures can be read by us, because we have the facility in our desktops. So we have been adhered to this one. Yes, it's a welcome step, because mainly because it's apart from the fact that it carries a listing, it's always an invasive one. And do not forget that any invasive catheterization in a cardiac patient, especially in a child, can result in even death. Yes. Because we have had that one in severe PH crisis, and obviously it is an invasive procedure. So we try to avoid it as much as possible.
You know, the Madam Suda, during my visit to Professor Shiaishi, and Shiaishi is one gentleman who can probably will carry his name in the next birth as well. So after retirement, he has so much of funding that he is carrying on. He is an altruist, I can share, and he is a philanthropist by heart. He is making pre-procedural prediction. You want to do Fontaine versus vis-a-vis, you want to do an petition. You want to do a petition, it should be which arteries to be done, whether it should be single artery, double artery, and they will have the reconstruction mathematical algorithms. And at the same time, he shared one painful thing, that people in Japan or the youngsters are not coming for CT-based surgeries, and same is worldwide, I suppose. So he is making 3D models which you can cut, you can stitch them before you go to the operation theatre. So with this, they know what you are going to see on the table, and they have already practiced it. And once this happens, the 6 hours time for surgery reduces to 2 hours, and so is the results.
I have inspiration.
I requested that man, Dr. Shiaishi man, had connected me to the person who made these models in Kyoto, and he has showed his willingness to come to India, but currently he is focusing on Japan and Europe. I think if things goes right and everything is in place, we will start at 3D modeling here as well, in which you can have a virtual dissection labs and virtual surgical labs. Yes, ma'am.
Just to mention that in America Institute Kochi, they are actually doing this project of AI, and as far as I know there is this project of AI where they are putting it, they're sort of taking it to the next level, combining it with the computer games. So if you wear that headgear, you can actually transport it to that virtual world where you can see that particular diseased portion of the heart with that abnormal anatomy, like you said, and they can actually visualize that BSD or visualize that particular disease segment, the exact location. And there's also that bit where you can get a 3D printing, like using AI with your inputs from CT and MRI, getting that 3D prints.
That is the way forward. I think we are lagging behind that, but we have to practically pursue it. But when you come next time to PJ, I will show you that.
Thank you so much.
Yes, ma'am.
So what Devata ma'am was telling us, we are involved in that VR project. So we have 2 of our headsets that are the Oculus headsets, and we have the software inside our systems. So once we connect with the systems, we don't need the systems after that. We are just with that headset, and one good CT imaging, we just inculcate into that headset and do the VR thing. So apart from those congenital things which we are doing, we now I've contacted Dr. Mahesh for that. So we are trying to incorporate if we can do anything for the coronaries for the same.
You invite us as to that. Yes, sir. Yes.
But the main important thing is you require a very good quality images. Good quality, and good quality comes with the radiation. That is something we have to need the increased kV. It is better for slightly more younger kids, but that is the main crux. If you have good quality images, it is very nice results.
And in invasive procedures come down to a very low level once we have those virtual symptoms.
Yes. May I request, so with this we close our section and thanks for your active participation and thank you so much.
बट फिर भी प्रक्रिया जरूरी हो गया